Okay, Tim, so I'm going to get things started today. And thank you all for coming. I really appreciate it. Again, on our regular Friday interdisciplinary seminar series at the Carolina Population Center. My name is Bob Hummer. I'm a faculty fellow at the Carolina Population Center and a professor in the Department of Sociology. And I'm here today to introduce our guest speaker today, Elizabeth Wrigley-Field from the University of Minnesota. Elizabeth is a assistant professor of sociology there and a faculty affiliate of the Minnesota Population Center, where she's been for not quite 5 years now. She grew up in New York City and ended up getting her BA in sociology from NYU, and also getting an MA in philosophy from NYU, and then went on to a graduate program at the University of Wisconsin-Madison, where she earned her MA and PhD in sociology, with the latter being in 2014. And after that, then she took a postdoc with the Robert Wood Johnson Foundation, which is one of the prestigious interdisciplinary postdoc programs in the country. And she did that up at back in New York at Columbia University between 2014 and 16, before taking her assistant professor position at Minnesota in 2016. I've really come to appreciate Elizabeth's work. She does a combination of what I would describe as formal demography, demographic methods, but substantively combining that with a focus on race and racism, including recent work on the police, focus on historical demography, looking back in time at issues of mortality and in the United States, and then a focus as well on infectious disease mortality, including COVID, where she's been doing some recent work and publishing work in that area. So all of those are really central topics to many of the things that's in the news today, and that's part of our dialogue in the social and health sciences. So Elizabeth has published her work in great journals like Demography, Demographic Research, and recently in the Proceedings of the National Academy of Sciences, work on mortality and race and racism that she'll be talking with you about today. So the title of her talk is "The Deaths America Treats as Normal." She'll be talking today the regular time, 45 minutes or so. And then if you have questions, just put your name in the chat. And then at the end, she'll call on you to ask your question. If you don't want to talk in person to give your question, you can always type it out in the Q&A, and I'll relay that to Elizabeth. But just put your name in the chat and afterwards, and we'll get a conversation going. So at this point, I'll turn it over to Elizabeth. Thank you for quote unquote coming or being with us today, and we're all looking forward to your talk.
Thanks so much for that introduction, Bob, and also for having me here. I'm going to do two things in this talk. I am going to show two very different projects whose common link is that they're about racism and pandemics. So I will show you some new research that I'm doing on the 1918 flu pandemic, where I want to argue that it illustrates a kind of general framework for thinking about inequality in pandemics, where it comes from, what it tells us, and what it doesn't. And then I also, so for that, I'm going to give you just kind of high-level results on the project, not the model details or anything like that, although I'm happy to get as detailed as you want in the discussion. I'm right in the middle of that project, so it's very, at the forefront of my mind. But then I want to shift gears and use pandemic mortality to give us a different perspective on what's been happening in the US for a long time, long before COVID. So first, I'm going to show you this research on racial disparities in flu and pneumonia mortality in US cities in the 1918 flu pandemic. I've got several collaborators on this project, including a wonderful grad student, Martin Eierman, who will be on the market next year and who is leading this project with me. And one of the big questions lurking underneath this work is, what can we learn from 1918 for today? And also, what can't we? So some things about 1918 will feel eerily familiar. For example, lots of earlier research has found that non-pharmaceutical interventions during that pandemic, so things like shutting down schools and theaters, enforcing quarantines, mandating masks, that those things did work to reduce mortality, but not by that much. And the reason they didn't work by that much is that they generally were not sustained for long enough. And why were they not sustained? Because they met with ferocious resistance. So for example, this is a Kansas newspaper saying, both the health commissioner and the health officer have been the target during the last few months for gobs of criticism and insubordination against what was termed the autocracy they were establishing in depriving the citizens of the privilege of freedom of action, the right to mingle with flu germs. So this historical relic is hard for us to relate to from our modern perspective, I know. Okay, but so some things haven't changed that much. But there's an important fact about 1918 that has been really underappreciated and is completely different from today. So to back up, the 1918 flu was very distinctive for at least 3 reasons. The first 2 are very well known. It was incredibly virulent, so very deadly, and it also had this strange W-shaped age pattern where young adults were hit really hard, along with the traditional kids and elders. But the third fact is not well known, which is that against a backdrop of really extreme racial inequality in all other years of that era, and I will say more about that later on, disparities in 1918 were surprisingly small. And this actually was known at the time, as this quote makes clear. This is the Reverend Francis Grimke saying, during these terrible weeks while the epidemic raged, God has been trying in a very pronouncedly conspicuous and vigorous way to beat a little sense into the white man's head, has been trying to show him the folly of the empty conceit of his vaunted race superiority by dealing with him just as he dealt with the peoples of darker hue. Okay, so people at the time definitely understood that the 1918 pandemic was hitting white populations very hard in a way that was unusual. And this is analyzed in a small amount of research, sort of shown on the right side of the screen here, but mostly it's been pretty forgotten in the story of 1918. So we started by just providing the first kind of systematic description of racial disparities in flu deaths for all US cities that had data in that year. So these are non-white, white flu and pneumonia mortality ratios for cities from 1910 to 1921. And in this context, non-white pretty much meant Black. And what I want you to see here is, first of all, those 1918 disparities were far smaller than other years, and that it lasted somewhat through the years where the pandemic continued to be relevant in a lot of cities in 1918 and to a lesser in 1919 and to a lesser extent in 1920. And second of all, there's extremely little variation in those disparities across cities. So they're both strikingly and also pretty uniformly small. And this is happening because the 1918 flu raised non-white mortality by a factor of 3, but white mortality by a factor of 5. And this is really driven by small disparities in those crucial young adult ages. So essentially this is happening because white mortality in those 20s and 30s ages was so extremely high. So we want to know why this is happening. And we considered a lot of different candidate explanations. So for example, when we started, we thought that non-pharmaceutical interventions, so again, those things like school closures and mask mandates, we thought that they might account for the small disparities. And this idea makes sense. The NPIs were certainly unique to 1918. Past research has shown that they mattered. And while the public health responses that cities organized were typically quite racist, for example, things like organizing hospitals and clinics for whites only in cities in the North as well as the South. But in spite of that, there also existed by this time fairly robust networks of Black municipal reformers who were able to push back against a lot of that racism. And so we thought that even if cities were only responding to the epidemic for whites in terms of like the clinics they opened and things like that, they might have ended up disproportionately helping the urban Black population just because its risk was otherwise so high. In the same way that, for example, Werner Troskin has argued that in spite of the racism of cities, endemic to their public works programs, when they organized sewer systems in the South, it disproportionately benefited the Black population, who otherwise would have been at the most risk of infectious disease. So one of the first things we did was use historical newspaper records to figure out the timing and duration of NPIs, and we were able to identify them for 52 cities. Like other studies, we found that these generally reduced mortality, but they did it in the same way for whites and non-white populations. They have no association with disparities. And the same thing is true for other city traits like segregation, proximity to military bases, air pollution. Some of these are associated with higher mortality, but none of them are associated with disparities. They don't actually seem to account for disparities at all. And so what we're pursuing is a different kind of explanation. The urban white and non-white populations in 1918 had very distinctive social histories. The white population was spread around the country and included many people born in the United States, many of those born in cities, but also included, especially in the Northeast and the Midwest, many, many immigrants. The non-white population was disproportionately Southern and disproportionately Black internal migrants, people born into deeply impoverished agricultural settings in the South, who then migrated to cities, first in the South and then in the North. And once in cities, they were made by law and by violent force to live in truly appalling conditions, just intensely crowded and dilapidated and dangerous. So rural origins, but then also living in the worst that cities had to offer. That's a very particular life course history of exposure. And these distinct exposure histories offer the possibility of explaining the small disparities through the interaction of that social history of each racial group with the natural history of the 1918 virus. So what do I mean by that? Okay, the details of these 6 distinct immunological hypotheses that we consider are complicated, and so I will not get into them, but the basic story is very simple. Non-white populations were either more likely to have had an earlier flu exposure that was protective in 1918, or less likely to have had an earlier flu exposure that was harmful. And the details of these hypotheses trade on 2 very distinctive biological features of the 1918 virus. One is that 1918 had this relatively mild spring wave before evolving to be more virulent and having this extremely deadly fall wave in 1918. And that means that early exposure to the virus could have conferred partial immunity. So this means that to the extent that the non-white population had this intense exposure early on because of the intensely crowded and dangerous conditions that they lived in, which really cannot be overstated, that they actually may have been somewhat protected when the virus evolved into its most deadly form. This is the only hypothesis in the existing literature about racial disparities. It was put forward by Alfred Crosby, a historian of the pandemic. The other distinctive feature of the 1918 flu is that it happened to have some combinations of similarities and differences to a very aggressive flu that circulated around 1890, which is sometimes called the Russian flu. And that means that people whose first flu exposure in their early childhood was to that 1890 pandemic strain might have been especially susceptible in 1918. Essentially, the idea is that for people who were first exposed to the 1890 flu in a critical developmental period for their immune system, then in 1918, when they encountered that virus, their bodies might have been flooded with an immune response that could not defeat the 1918 virus, but would produce deadly cytokine storms while crowding out a more effective immune response. So this hypothesis has been developed by people like Alain Gagnon as a way to explain the very high mortality of young adults in 1918. And we think that it implies that urban non-white populations who disproportionately grew up not in cities, but in rural areas, might have been relatively spared this harmful exposure, while the urban white population, which disproportionately had spent their whole lives in big cities, was more exposed. So I'll give you just a high-level summary of the results, starting with that potentially protective spring wave. And basically, we find that cities that had a worse spring wave had lower fall mortality in the way that we would predict if this hypothesis is right, only for non-white populations. And so maybe that's a protective immunity that's only detectable at very high levels of population exposure. But we don't generally find this, we don't find this relationship in general. We don't find it for the white population. So we also think this may reflect not an immunological, but a behavioral response, where communities that had already experienced the virus as deadly in 1918 were more likely to embrace social distancing in ways that actually might be sort of familiar to us looking at differential responses to the coronavirus today. So I'll say just a bit more about the idea that early childhood exposure to the 1890 flu could have produced cytokine storms in 1918 through a mechanism called immunological imprinting. And it's worth saying that our method here is we are not going to have great ways, a great single test of this hypothesis, not even close. So our method is to think hard about what it implies in a lot of different domains and try to evaluate those assumptions as best we can and sort of triangulate. And specifically, these hypotheses make assumptions in two domains that we can exploit: the differences in how many white and non-white urban residents were born in urban areas where they would have had greater childhood exposure, and also how wide or narrow is the range of cohorts that might plausibly have been imprinted by the 1890 pandemic, and what does that imply about the age effects that we would expect to see in 1918. So for example, one question we try to answer is, could the huge jump in young adult mortality for whites compared to their surrounding ages, could that jump plausibly be driven by this immunological imprinting mechanism? How big would that imprinting effect need to be? And the answer is it would need to be really, really big unless imprinting was close to ubiquitous in the white population, in these cohorts of whites, I should say. And so we also back out how high would historical flu transmission rates have needed to be to produce such high imprinting rates. And basically the upshot is they're not crazy. They're actually in line with historical flu attack rates. But you basically have to imagine a whole bunch of parameters lining up just right if a story like this is going to explain why young adults had such overwhelmingly high mortality in 1918 to produce these small disparities overall. So stepping back from these details, this hypothesis is interesting to me because it offers the possibility of a consilience between these three distinctive facts about 1918. So if it's really about these early childhood exposures, then we potentially have a way to explain some of the virulence, the weird age pattern, and the strikingly small disparities all together. That said, I don't think any analysis with the data that is available is going to give us anything like a definitive answer as to whether these hypotheses are right, although I think there's a lot that we can rule out with the analyses that we did. So what I really want to emphasize here is the framework that this gives us, which is that what happens in the pandemic reflects what was happening before the pandemic, but it does so mediated by the pandemic's specific biology. And for me, this is really a cautionary tale about reading 1918 forward into 2020 and assuming that there's some sort of universal path of pandemics that we're on today, or that all pandemics interact with social inequality and reproduce inequality in the same ways. Or for example, or for that matter, that racial group boundaries have this exact same meanings today that they did a century ago. The social immunology frameworks suggest, on the contrary, that drawing historical analogies requires us to be very careful and very attentive to the details to understand how particular social histories intersect with particular natural histories of microbes. So that's, to me, that's the biggest lesson from our 1918 analysis. And now I'm going to shift gears. And in the second part of this talk, I want to give you a different perspective, something that really changed the way that I understood the 1918 flu when James Feigenbaum, Chris Moeller, and I found it about 2 years ago. This graph shows urban infectious mortality across years for whites. 1918 is almost literally off the charts. But that huge spike in mortality for whites, that was still less than the infectious mortality that urban Black populations of that era experienced every single year. When James, Chris, and I first found this, we assumed we'd made a mistake. We looked at our data lots of different ways, different collections of cities, different measures of infectious mortality, standardizing for age, not standardizing for age, et cetera, et cetera. But it turns out that it's true, and not just in infectious mortality, but in total mortality as well. White mortality during the 1918 flu was less than Black mortality was almost every single year until the 1930s. And the white population's life expectancy in 1918 was still higher than the Black population's life expectancy had ever been. This May, I started wondering whether the same thing would be true in this pandemic. Racial inequality in mortality is still extreme. The best ever Black mortality and life expectancy in US history, which are denoted by these light blue dashed lines on this graph, those are similar to levels that white people experienced 20 or 30 years earlier. So one way you can think about the size of this disparity is it's as if the Black population has simply been denied 2 or 3 decades of mortality progress in terms of what was experienced by whites. So I asked, how does that gap compare with COVID mortality? And specifically, how many excess deaths among whites in the COVID-19 pandemic would it take to raise white mortality to the best ever Black levels? So in other words, I took the most recent white life tables from 2017 and asked, what do I need to do to get these to average out to the same levels for Black life tables of 2014, which was the best ever year before the opioid pandemic fully took hold. And the mortality metric that I used here is age standardized because the Black population is a lot younger than the white population. That's what the graph on the right is illustrating. And to do this, I had to assume some age structure of mortality in the pandemic. So I had to decide what ages are these hypothetical excess white deaths happening at. So I just made 2 different assumptions in turn. One is that white excess mortality in 2020 had the same shape as all-cause white mortality did in pre-pandemic times. And the other is that white excess mortality in 2020 has the same shape as confirmed COVID mortality among whites. So this gives me this range of estimates. I found that to raise white mortality to the lowest ever Black mortality would take at least 400,000 excess white deaths over the course of 2020, and perhaps 1 million deaths for white life expectancy to fall to the best ever Black level. For comparison, the CDC numbers put COVID deaths to whites in 2020 at a little below 200,000. The excess deaths are certainly higher than the confirmed COVID deaths, but not twice as high. So this is telling us that even if the Black population had been hypothetically immune to the coronavirus, it probably still would have had higher mortality in 2020 than the white population actually had. And of course, we know that in reality, the Black population, along with immigrant and indigenous populations, has had the heaviest COVID toll. As a metric for understanding that toll, More recently, I did another comparison that sort of goes the other way around. So in what I just showed you, I used COVID mortality for whites as a metric to understand how big the Black-white mortality difference is in non-pandemic times. And now I want to use the Black-white mortality difference in non-pandemic times to tell you something about how big COVID mortality is in the Black population. So this means the first new number I'm going to give you has nothing to do with COVID. I asked if we counterfactually assigned the Black population to have white pre-pandemic mortality rates, age-specific mortality rates, how many lives would be saved compared to Black pre-pandemic rates? So it's sort of the inverse question. And the answer I got is about 75,000, which, to put it in perspective, is just slightly larger than the number of Black people dying of cancer every year. So you could think about it as preventing the extra deaths that Black people have compared to white people is similar in scale to curing cancer in the Black population. And you should know that this number is artificially low. The number comes from using the age distribution of the Black population as it currently exists. But the Black population is very young because its mortality is very high. So that 75,000 is what you'd get if you had a 1-year blip of white mortality levels after a long period of much higher mortality. Ironically, it's a much smaller number of deaths than you would get in a steady state low mortality scenario. But let's go with this artificially low number and say that in non-pandemic times, we're talking about 75,000 excess Black deaths every year, like we had cured cancer. Now, how does that compare to COVID deaths? CDC data as of October 3rd estimated that the excess mortality rate for the Black population was up about 1/3 from its typical levels before the pandemic. We don't have better updated excess mortality so far. But over the whole year, if that same October 3rd estimate held, just extended for the remaining 3 months of the year, that would imply about 119,000 excess deaths in the Black population in 2020. More than cancer, more than the deaths representing that Black-white inequality in a typical year. So what I hope you have taken from this is just that the utter catastrophe of this year is quite profound in its inequality. So now I want to back up and return to this main result that it would take 400,000 excess white deaths this year to match Black mortality in its best year. What does this tell us? Pandemics are special because they are intimately linked to social action. Now, we have not done one fraction of what I think we should do to stop this pandemic and to make stopping it survivable for much of the population with real support for staying home, real protection for those who can't. But from the perspective of just 9 months ago, what we have done is staggering. And what stands out to me the most is just the speed with which we changed our assumptions about what a reasonable change to prevent the spread of COVID is. So for me, it was about 10 days in March that upended all of my assumptions and plans for the next, let's say, 2 years of my life. And I think something like that was true for many of us. From the perspective of today, with the reality of the pandemic, it's astonishing how little we've done. But from the perspective of last February, it's astonishing how much we've changed. Which poses the question, what if we were as serious about stopping deaths associated with racism as we are about stopping deaths associated with pandemics? In the last 6 years or so, one radical response to racism has entered the mainstream of discussion. I'm talking about reparations. These proposals focus on a common lever for redressing American inequality, and that lever is wealth. So for example, Darity and Mullen offer detailed proposals for congressional committees to estimate the wealth that individuals lost due to slavery, while Catherine Frank argues for community land trusts, actually in North Carolina, to be created as compensation for land stolen after the formal end of slavery. So the details are very different, but the target is the same, it's wealth. And this makes sense. There is no single greater proxy for power than wealth. African Americans were enslaved to create it. Indigenous peoples were dispossessed to take control of it, and nothing else confers as much control. So wealth must be a centerpiece of any form of redress for racism. And yet, grappling with the magnitude of inequality in American mortality, this pandemic's worth of needless deaths every year, has made me wonder about other levers that might be needed as well. If wealth is the single best proxy for power, then I would argue that time, how much time we get, how much we get to control it, might be the best single proxy for freedom. And as much as the normal operation of our society is built on stealing wealth, so it is also built on stealing time, a theft just as central to slavery, the theft of labor power. Today, that theft looks different. It's the loss of time to work without autonomy, scheduled unpredictably, located far from the neighborhoods where Black workers live. It is the cruelty of administrative burdens imposed on the poor to access social services. It is the staggering losses of incarceration. And amid all these losses and all this theft, I want to argue that this loss, this theft is also distinctive, that losing time to death is a distinctive harm because of how the meanings that we make in our lives unfold in time. So here's what I mean. Death means the loss of connections, which are losses that reverberate for others. It means the loss of our effects on the world, the loss of the chance to pursue our personal projects. It means losing the chance to see our loved ones and ourselves at different stages, to let our ideas unfurl in time, to develop this synthesis of wisdom. Because we're social creatures and we're creatures who learn so well, aging gives us different kinds of perspectives on the world. It's not just a cliche to say that aging brings the possibility of wisdom. I think it's actually something very deep about the kinds of organisms that we are. And so cutting all these lives short is also a huge cultural loss. And I have to say that I always feel a little ambivalent talking about it that way, because I never want to distract from the fact that the biggest, most profound loss of a death is always the loss to the person whose life was taken. But I think it also can be important to name the harm fully. These early deaths are robbing all of us of the effects that the people killed too soon should have had on the world. The things that make for a meaningful life really get their meaning from how they extend over our lives and our loved ones' lives. And so cutting someone's life short robs them and the people they love of that meaning. And so, lurking underneath these statistical disparities are really these most human harms. Would these losses be solved by wealth-based reparations? Perhaps. I suspect that such reparations would do more to resolve these disparities than any other single policy would. But they might not solve the ways that the medical system treats Black patients with skepticism and hostility, the way that, for example, doctors devalue Black pain, or the ways that the development of new drugs and surgical procedures still often relies on experimenting on the most vulnerable patients in order to reduce the risk to everybody else. And they might not really solve the deadly consequences of environmental racism, at least not in a way that feels satisfactory. So the way that wealth lets you buy your way out of air pollution, for example, is by offering you the possibility of moving. And the right to move freely is one of the most fundamental civil rights that a huge portion of the civil rights struggle in the United States has been about. And yet we might also wish to embrace a right to stay put, to stay where your history and your family are and have that place be safe. Health reparations could encompass programs like the mass expansion of medicine through training doctors and nurses of color. It could encompass mass environmental cleanups, but kind of reparations at the community level. But more than any specific policy, what I hope we will embrace is a radical scale of action. Racism produces a pandemic's worth of needless death every single year. That was true a century ago, it's still true today. So our tools for fighting it should be pandemic scale tools also. Our imagination and our social ambition should not be limited by how accustomed the United States is to profound racial inequality. Instead of asking what changes are realistic, we should change the question to ask simply, what will work? Thank you.
Thank you, Elizabeth, for that amazing talk. It's just fabulous and important. So, yeah. So anyway, I want to get going with the Q&A in the chat. Again, if you have questions, just please list your name in the chat, and I'll try to help you, Elizabeth, kind of keep track and so forth. We do have two questions already appeared in the Q&A. One of those is just a request to share the book titles and authors on these slides. So I wonder if at some point if we can do that afterwards. I'll let you comment on that. But then Jessica Sue has the first question here. Thanks for the fascinating talk and hugely important study. I'm curious if you're able to partition out the excess Black deaths into those attributed to disproportionate exposure, e.g. occupational risk related to frontline service work versus disproportionate mortality, healthcare access, and quality. The distinction might help to identify different policy levers, although I agree that wealth is related to both.
Yeah, so I have not done any of this work, but there are a number of people doing important work on, in the context of COVID, on trying to understand how much risk is because of differential exposure and how much is because of mortality conditional on exposure. And early in the pandemic, I think a lot of people assumed that it was really going to be about resistance to disease. So there was all the discussion about comorbidities and so on. And I think at this point, all of the studies seem to be pointing in the same direction, which is that it really is the exposure piece that's key. So we've seen that with a number of populations that are really different from each other. People in the VA system, people in Michigan, there's one in New Jersey, I think, and it seems to all point in the same direction. So it seems like it's really exposures and in particular workplaces that seem to matter. And I suspect that I have not seen any study yet that does a good job of putting together workplaces with residential housing arrangements. But I suspect that when we figure out how to do that, that there's a good chance that what we'll see is that workplaces combined with multi-generational homes where one person works in a job that's high exposure is going to turn out to have driven a lot of the disproportionate COVID mortality. There's one more thing though I want to say about that, which is that when we think about workplaces as a site of risk, I think what we often imagine is jobs that are sort of like intrinsically high exposure in some way. And there's a really nice working paper by Noreen Goldman and Teresa Androfsky, where they argue that actually that's not the key. So they classify occupations by their sort of intrinsic exposure because of the occupational tasks that they involve. And they find that actually white workers are disproportionately employed in the occupations that are intrinsically high exposure. But what seems to be going on is that Black and Hispanic workers are disproportionately employed in occupations that have some exposure where they don't get adequate protection. So things like PPE or rearrangements of how work is organized. And so it seems to me like it really is also a question about workplace power. And in terms of the books, I can just send you the slides if that's helpful, if you want to circulate them.
That would be great. Thanks, Elizabeth. Esther Chung, you have a question?
Hi, yes, thanks, Bob. Thank you. This is a super interesting talk. I was wondering if you've looked at these disparities by gender. And if you could describe, if not, could you describe what your hypothesis would be, given some of the disparities in Black-white mortality by gender?
This is a great question, and I've only looked at this a little bit. In the US as a whole, so I should say this is the last time I checked, this was a couple of months ago, and the CDC does add additional data, so hopefully this has changed. But when I was working most closely with the national data, we did not have any national data that looked at race and gender simultaneously. And there's actually a little shocking, some of the things that feel like sort of basic data collection that is just not available for the country as a whole. So I've looked at this a little bit more in Minnesota, where I'm doing COVID research and we have death certificates. So we don't have data on COVID tests or anything like that. We just have the deaths. And there is an enormous gender divide in COVID mortality. And that is true for all racial groups that we've seen. So men are at just much greater risk, conditional on age. In Minnesota, that interacts in a sort of interesting way with the particular age composition of the white and Black populations that we have here, where our Black population, unlike most states, is a disproportionately immigrant population. We have a lot of East African immigrants in Minnesota, and there's a lot of older women more so than older men in a way that creates a really interesting age skew. And so it's, I think the short version is it's true for everybody that men are at greater risk. But in Minnesota, a lot of the disproportionate deaths are driven by women, but I think that has more to do with our demographics.
Thank you again. Carmen Gutierrez has listed a paper in the chat that it would be great to circulate on racial and ethnic disparities and COVID health risks by employment and household composition. So I'm not sure how to do. I wonder if Tim could distribute that to the whole group. Okay, because it just came to the panelists. So great, thank you. Elizabeth, I wanted to follow up with a question on your thoughts on the health reparations, which I find fascinating. And I also, I'm unsure if if you've heard about, have seen, or what are any ways in which traction on these kind of ideas could be, to get underway. So, are there champions for such ideas that you know about in, key legislative bodies? If so, whom might those be? Have you seen such things unfolding at all in city, states, and so forth? So I wonder if you could comment further about the ideas. Sound fascinating, just any traction or implementation that you're aware of.
The short answer is no, but I think the longer answer is more complicated than that, which is that this summer, after the death of George Floyd and the uprising that followed that in Minneapolis and then in many, many, many other cities in the country, there was a real shift, at least at the level of rhetoric, in how many cities have talked about health. So a number of cities, Milwaukee is one of them, adopted the language of racism being a public health emergency, and had a number of implications of that in terms of the kinds of metrics that they track, what would be health priority, what would be considered priorities in decision-making and trade-offs. And I think what remains to be seen is how much will this remain a shift at the level of rhetoric, and how much does it become things that actually change what health departments do and what cities do. And I'm always a little skeptical about that. I'm pretty cynical, I think, about the way that language of anti-racism gets adopted and co-opted. But I also think that the moment that we're in, to me, feels like one that is very in flux, partly because the COVID context has created so much upending of assumptions about the way that things will operate, and partly I think also because of the social movement context following George Floyd's murder. So I mean, if you had asked me back in May, if I had thought there would be a national political conversation about defunding or even abolishing the police, I would have not found that very plausible, but here we are. So I do think that we're in a context where things can change very quickly in ways that we wouldn't have predicted. And that's, I guess, the context that makes me feel more hopeful about the ability to have discussions like, what would reparations really look like, or what should they look like?
Thank you. That's fascinating and helpful. I know that there's a lot of interest in these kind of issues among both faculty and students here. So it would be wonderful to build the thoughts you have into the current ongoing conversations here. Megan Reynolds has a comment. And Megan, I don't know if you want to mention this in person.
Yeah. Hey, Bob, thanks. I just wanted to draw people's attention to some of the more kind of concrete efforts to work with legislators, both federal and I think at the state level, around this wealth gap, in particular through the cancellation of educational debt, which is very disproportionately disadvantages Black populations. And so Louise Seamster and some other folks, I think, were talking with Liz Warren during her primary fight and getting a lot of attention for their proposals to cancel educational debt. And a piecemeal approach like that may not be the most effective, but it's certainly, I think, going to go a lot further than no approach at all.
Sorry, it's going to go a lot further than what?
Than no approach at all.
Totally. Yeah, I think the proposals around canceling educational debt to me are very exciting. One of the big debates in that area, of course, is about what educational debt and for whom, and is it for everybody? And there's a lot of, I think there's a lot of skepticism from some sides about the idea of canceling debt for occupations that would be highly paid, like lawyers and doctors, in terms of its effects on inequality. I guess I'll just say I think about that pretty differently, because I feel like one of the things that is radically needed in this country is a mass expansion of rural health care, an expansion of primary care and geriatric care, kinds of work that are hard to get doctors to do because they don't pay as well. And that if we want to have doctors and if we want to have lawyers doing public service work, we have to actually make it as possible as we can for people to leave those kinds of, to leave their schooling and take lower paying jobs without feeling the debt hanging over them. So I'm really enthusiastic and excited about proposals to cancel educational debt.
Thank you. Alexis Dennis.
Hi, thank you so much first for an incredible talk. I think I'm going to be thinking about it for a long time after this. So I was struck by your introduction of a concept of health reparations, and I'm trying to figure out how you would think it's conceptually distinct from a concept of just dismantling structural racism in the US. And then I guess an add-on to that question is, like, your talk, in your talk, we've been talking about racism in terms of Black and white health disparities. But we also know that racism impacts other historically marginalized groups as well in the US, and it's impacted those groups in different ways. And so I'm also wondering, like, how would your health reparations framework or concept also be broad enough to think about, health disparities among Indigenous populations, for example, or Hispanic populations?
Yeah, those are both great questions, and thank you for the kind words about the talk also. So on the question of health reparations versus dismantling structural racism, I mean, on one level, all of these ideas are pretty vague. So I think there's a lot of ways in which we're probably all talking about the same kinds of ideas with different language. Part of why I chose the language of health reparations for me in thinking about this is the emphasis that I think it puts on action and on repair. And both of those seem important to me. So the repair piece, because we are not just talking about some conception of, the US is fundamentally a meritocracy, but it has these deviations from that reflect racism, and we can just resolve the deviations. To me, the language of repair gets closer to what I think is the real situation of how deeply this country was founded on theft of lives and wealth and time and the things that, and humanity and the things that matter the most to us, and that has to be repaired. And the action component is important to me, because how I came to this was really thinking about just this gap between what we do to stop pandemics and what we don't do to stop racism. And so the, thinking about this in this sort of active way is something I was trying to capture in the language. And actually I would be very curious and very open to feedback about, is that language actually capturing those things in the way that I want it to? And in terms of the question about other forms of racism, I think that's really right. So one thing that comes out in the COVID work that I am doing in Minnesota, for example, is like every racial group in Minnesota has had a very distinctive pattern of risk in the pandemic. So risks at different times, risks that seem like they're coming potentially from different sources. And it suggests that we have to understand in a lot of concreteness what inequalities look like, I think, to be able to redress them, not just in a kind of broad brush sense. I think that the argument that I am making about anti-Black racism extends very naturally also to racism against Indigenous people, to racism against immigrants. And so I think there are certainly analogous cases that could be made about cases for reparations and repair. And when you start to do that, I think there is a sense in which it sort of opens up a potential for a kind of infinite regress, right? So you start to think about like, well, is it just people in US borders then? What about the role that the United States has played in propping up violence and producing violence around the world? Isn't there a similar sense in which we owe repair in that context too? And I guess my answer to that personally is yes, and that it's hard to conceptualize, at least for me, what all the implications of that are, but that at least the first step, I think, is to not shy away from it. So I guess I would summarize this answer as saying that I agree with you that this is not just about, that the kind of argument I'm making is not really just about anti-Black racism, but is about many other things as well. And the implications of that, I think, suggest that we should expect to be fighting for the world to look quite fundamentally different than it does in ways that might even be hard for us to imagine.
Thank you so much.
Thank you.
Elizabeth, I want to take the pride of going back to the part of the talk on the flu epidemic of 1918 and asking a technical, hopefully I think a short question on that, just clarification. And then second, kind of the meaning for some of that for more current times. The more technical questions, you showed the lower disparities in 1918, some degree in 1919, some degree in 1920 compared to surrounding years. Very quickly, were those relative differences or absolute differences in that graph?
Those were relative.
Okay, and
so
can you comment on, because as you know, I mean the different scale of those two measures of disparity could vary. So
yeah, that's exactly right. So if we measured disparity as the absolute difference in the death rates, the disparity actually would be larger in 1918 because the death rates that year for both populations were so huge that it's just sort of off the charts. To me, the ratio measure feels more like it's capturing what we actually want to capture in terms of differential risk for the Black population. But we did worry a lot about, every time you have a ratio measure, it tends to be the case just mathematically that it's smaller when the base is bigger and bigger when the base is smaller. And is that really what's driving these small ratios? And I don't think that it is. So one thing we did was look at variation across cities in other years to kind of compare, like, is there just sort of a spectrum where higher mortality years have lower disparities, and this is kind of along that spectrum? And the answer to that was not really. 1918 is actually just really distinctive in how small the disparities were, and that made me feel better about that.
Thank you. And then the second part of the question was, so with these lower disparities then in 1918, 1920, I started to think about the opioid epidemic a bit, and all the attention that has gotten with that early on, at least the heightened death rates among white Americans compared to other groups, especially low-educated white American. Now that's not true anymore, is my understanding, but it really caught the attention of the media, politicians, scientists, and so forth. So I wanted to hear a little bit from you you talked about the lesson of history, while important, it's not necessarily applicable to all the different scenarios. I wanted to hear a little bit of your thoughts about why, what you think was going on with the opioid epidemic and why we saw such a different kind of unfolding by race in that case.
This is a great question for which I only have speculative answers because I don't really know. But my speculation is two related things. One is the way that many doctors devalue Black pain and are skeptical of reports of Black pain may have had a somewhat protective effect when it comes to addictive pain medications. And related to that, there's some great work by the historian Donna Murch on race and opioids, where she argues that part of how opioids were able to take such hold and the way that they were able to become so widely prescribed is that they marketed themselves to doctors as, or they were marketed rather by Purdue and other pharmaceuticals to doctors as non-addictive, and a lot of that marketing was really grounded in racism. And so it was basically like, think about the profile of patients who get addicted to drugs. These patients are really different, they're white. And so that undercut a lot. I mean, obviously not in so many words, but she shows that they really relied on racist imagery in order to kind of make that case to doctors, which let doctors feel more comfortable writing those prescriptions. So I think that's part of it too.
Thank you. Thanks very much. And one last question. Ilya Gutin has a question for you, and then that'll be it, and we'll move on for the day. So Ilya.
Thanks, Bob. And thanks, Elizabeth, for the great talk. I think this maybe touches on what Bob was asking before, because I was really struck by your comment about being aware of how the patterns intersect with the underlying biology of the whatever disease is at in question. My question specifically is, in doing all this work, if you've kind of formed any thoughts about how like the narratives around exposure versus underlying vulnerability and like the extent to which there's like a specific mortality rate associated with a specific disease, how all these things come together to maybe contribute to social narratives about racial disparities in health or just inequalities in health, like stereotypes and things like that, like how all these things kind of have feedback mechanisms on one another.
Yeah, I think that's right. I mean, I think we have such strong folk narratives around race as a biological category and that the supposed biological boundaries of the category and also behavior kind of driving disparities, I think is so deeply entrenched in the way that our culture at large thinks about health outcomes. And I think that is reflected in the way people have talked about these disparities. The number one question that I get from non-academic audiences when I talk about this, when I talk about COVID disparities in particular, is, well, isn't it all just vitamin D? Which I think kind of reflects that, that worldview a lot. So, so I agree with you.
And with that, it's 1 o'clock. It's time for everybody to move on their way. Elizabeth will be meeting with graduates, trainees and postdoctoral trainees in just a minute. So I want to thank you all for coming today. And most of all, I want to thank Elizabeth for a fascinating talk, great interchange with all of us. Thank you again for your time, for all the science you're doing in these areas, which is extraordinarily important. So with that, please give her a virtual claps and then we'll sign off and be on our way. Thank you again, Elizabeth.
Thank you all so much. This was really great to get to talk with you.